Prashant,
बोला.
I think you can start. Sir, Dattatreya sir has joined.
Datta sir, good afternoon. Candidates have joined. So first we'll ask
Prashant,
Dr. Prasanna. Dr. Prasanna, are you ready with the presentation?
Yes, sir.
Dattatreya sir, can we ask Dr. Prasanna to start?
Yes, please.
Okay. Dr. Prasanna, you can start.
Please introduce yourself first, Dr. Prasanna, and then.
Sir, this is Dr. Prasanna from senior resident third year from AIMS Rishikesh, sir.
Yeah, you can start. How much time are you having for the
Sir, usually we give 45 minutes for long case presentations. So whatever Dr. Prasanna will present, the questions will be directed towards Dr. Sonal. And whatever Dr. Sonal will present, the questions will be directed towards Dr. Prasanna. So that each can know each other's case. And usually 45 minutes timer, so around 350 we will finish this. And then the OSCE PPT will be for 10 minutes each.
Okay. Yeah.
Yes.
My patient is a 23-year-old right-handed male who is a fruit vendor, resident of Meerut, Uttar Pradesh, had no formal schooling, presented with a chief complaint of headache for 8 months, left-sided hearing loss and facial numbness for 8 months, right facial deviation for 7 months, limb weakness, left-sided for 5 months, followed by right side for 3 months, right neck tilt and difficulty swallowing for 3 months.
Your slides are not moving. Yes, okay.
And into the history of present illness, patient was apparently all right 8 months back when he started having complaint of headache for 8 months over the back of the head, which was intermittent, dull aching, mild in intensity initially, who had 2 to 3 episodes per day with no diurnal variation, and they used to get relief with over-the-counter pain medication
Dr.
initially.
Prasanna, can you make your slides on the this slideshow?
Yes, sir. I'll put it on this
Presentation mode, yeah.
Is it visible, sir? Sir?
It is visible.
Yes, okay.
Yes. Patient was apparently all right 8 months back when he started having complaint of headache for 8 months over the back of the head, which was intermittent, dull aching, mild in intensity. Initially had 2 to 3 episodes per day with no diurnal variation, which used to get relieved with over-the-counter pain medication initially, but later frequency of the medication increased only with mild relief, which was not aggravated with coughing or straining. But later, patient started experiencing holocranial headache from 4 months, which was aggravated in early morning hours, which was not relieved with medication. It was also associated with blurring of vision for 3 months, which was progressive in nature. And he noticed difficulty identifying faces at a distance initially. And later he found difficulty in reading the price tags also. And gradually he had complete loss of vision only to perceive light in front of him, which was not associated with any diplopia, eye pain, or transient visual loss. Patient had underwent VP surgery 3 months back, post which he had relief in headache, but vision he did not have any improvement. Complaint of left-sided hearing loss for 8 months when he noticed initially that he was unable to hear the adhan over the mic and vehicle honking, and slowly he started having difficulty hearing customers too, and he had to turn his head to the right side, and also while using phone he noticed he had to use his right ear, which was gradually progressive in nature. Initially he only had difficulty hearing at the market, but slowly he had difficulty recognizing words spoken at his family also, and he didn't notice any improvement in hearing even at the home or market. There is no sudden discomfort while increasing the volume of a TV, and now patient has stopped perceiving sounds from left ear, which was not associated with tinnitus, vertigo, ear discharge, or fullness. There was no history of vesicles over the lips, angle of mouth, cheeks, or ear. He has also complained of numbness over the complete left half of the face for 8 months when he noticed he had multiple cuts while shaving his beard and numbness while washing his face with both cold and hot water. He also noticed difficulty chewing the food over the left side, and he was unable to chew hard objects from the left side, and he had to chew from his right side from 3 months, which was not associated with any pain while chewing or burning or tingling sensation over the face. 1 month into the illness, family noticed that patient had subtle right side facial deviation, and gradually patient also noticed in the mirror from 7 months with accumulation of food particles in the left cheek, and he also had history of spilling of saliva and water from the left half of the mouth. He had no difficulty closing of the eyes, but there was no history of redness or watering of the eyes. Slowly, he has also noticed difficulty articulating syllables like mama and baba. He has also complained of imbalance while walking for 5 months when he started feeling unsteady while walking, unnoticed while pushing his fruit baskets, and he had a tendency to weigh towards the left side and occasionally holds onto the nearby support, which has gradually progressed over the next few weeks. And he also had to try multiple times picking up a coin or a fruit placed on the cart, and he used to experience tremors while handling the fruit basket to the customers. He has also history of spontaneous nodding yes movement of the head for 2 months. He began to notice generalized weakness of the limbs, more on the left side, with stiffness, and patient initially started having difficulty wearing chappals, which has progressed to difficulty climbing stairs, difficulty getting up from squatting position, and difficulty picking up berries and counting money, and picking up things from the overhead cabin with left hand, which has slowly progressed to the right side, upper and lower limb. Despite this, he continued his daily routine activities of selling fruits initially, but he had to stop his work from 4 months, and he was completely wheelchair bound from 3 months, and now he needs minimal help of his family to perform the daily routine. He has also history of difficulty turning head to the right side from 3 months, with neck tail to the right side for 2 months, and drooping of the left shoulder for 2 months. He has also noticed difficulty swallowing liquids from 1 month with nasal regurgitation, and slowly it has progressed to now patient having difficulty swallowing solids too, and was on complete nasogastric feeds from 3 months. Patient has also family has also noticed that his voice has become nasal with hoarse in nature, with difficulty articulating words. Currently, patient was oriented, conscious, and have no useful vision in both eyes, able to perceive light, have no hearing from the left ear, need support to get up from the bed, and also a person support on the left side to go up to the washroom due to both weakness and visual difficulty, and need minimal support to comb his hair, brush his teeth, and he was able to tell when he needs to urinate or defecate, and he is on nasogastric pills. Patient was initially taken to a local private hospital for these complaints 4 months back when he was evaluated and was advised surgery, but have denied for the same. Later, 1 month after that, he went to another hospital and he has underwent left side vision, following which his headache is subsided, but there was no improvement in the vision. There was no history of behavioral disturbances, no history of difficulty appreciating smells, no diplopia or ptosis present. There was no history of numbness or cotton wool sensation over the body except face, and was able to appreciate hot and cold water while bathing, appreciate cold clothes while wearing, and can appreciate slippage of the footwear. No history of difficulty manipulating food in the mouth, no history of increased or decreased sweating, dryness of forehead, eyes or mouth, normal appetite. He is having normal appetite with no history of weight loss, no history of seizures, fever, loss of consciousness present, no bowel or bladder disturbances present, no history of trauma present, and no neurocutaneous markers present. And he is not a known diabetic, hypertensive, or asthmatic. There was no history of tuberculosis or TB contact, no history of previous surgeries other than VP shunting, no known drug allergies. His sleep was disturbed due to the headache. He was on nasogastric feeds from 3 months. There were no addictions, and family history is nil significant. To summarize, my patient is a 23-year-old right-handed male with surgery post left-sided vision, headache, having headache, left side hearing loss for 8 months, facial deviation for 7 months, limb weakness for 5 months, neck tilt and difficulty swallowing for 3 months. And subject involved would be bilateral second nerve, left side fifth, seventh element type, eighth sensory neural, retrocochlear, ninth nerve, 10th nerve, and 11th cranial nerve, with middle cerebellar peduncle and cerebellar involvement, with both corticospinal, left more than right involvement, with features of raised ICP and no features of autonomic and sensory involvement. Sir, should I proceed with examination?
So here I think Prashant, what do we do? Sonal has to comment.
So you can ask questions now, and then she can proceed.
So no, is Sonal now the other candidate is going to answer or?
Yes, sir.
Acha. So we have to ask questions to Sonal now?
Yes, sir.
So Sonal also first we can talk to Prasanna, what she has presented.
Sir.
Sir, for Prasanna's case, Sonal will answer, and for Sonal's case, Prasanna will answer.
Okay.
So is Sonal there? Sonal is there?
Yes, sir, she's online. Dattatreya, sir, your voice is a little low.
Low. Okay.
Can you increase the volume?
Is it okay now or is it still low?
Still low, sir.
Because my thing is
Dr. Sonal, you've gone through the case?
Yes, sir.
Now we can ask question to Sonal, Dattatreya sir.
Yes, we can ask.
You ask you start first asking Sonal.
Yeah. So Sonal, what do you think? Can you hear me, Sonal?
Yes.
Yes, sir.
Yeah. So tell me, what do you about all this history? What do you feel? What is going on?
So first of all, this 23-year-old male presented with complaint of headache. Initially, the headache seemed to be of dural stretch type since it was localized to the back of head. And later, the patient started having holocranial headache associated with blurring of vision. So initially dural stretch and then later turned to raised ICP type of headache. Next, the patient has presented with progressive hearing loss. Which looks hearing loss in the left side, which appears to be retrocochlear type. Since patient does not have any masking feature, he does not have any this recruitment phenomenon is also absent on history. Associated with there is features of left side facial palsy. It is difficult to tell whether it is UMN or LMN since eye closure is proper. He is not giving an history of reduced blinking also. Then, other than that, patient also gives history of left-sided facial numbness, and difficulty in chewing, which points towards left side fifth motor as well as sensory involvement, also since 8 months. Then, patient also has complaint of bilateral upper limb and lower limb weakness, which is left followed by right. This appears to be a little bit different since initial history is pointing towards an extra-axial lesion involving the left CP angle. But since first involvement is on the left side, that is quite odd. Other than that, then patient has patient has history of right neck tilt and difficulty in turning the head towards neck towards the right side, which points towards involvement of the left side sternocleidomastoid 11th cranial nerve involvement, along with lower cranial nerve involvement with difficulty in swallowing.
No, now you said that you are worried about the right facial weakness, right? Whether you don't know whether it is
Yes, sir. On his
low motor neuron. Why you are saying so? You are suspecting something?
Sir, on history-wise, since the patient has hearing loss also and headache also, it points towards the facial weakness. The patient gives history that there is drooling of saliva from the left corner of mouth along with facial deviation towards the right side. But there is no improper eye closure. So difficult to ascertain whether it is UMN or LMN, but based upon the other history, it should be LMN type.
No, see, what is the, why you are saying, what will be the UMN feature of a facial palsy?
So then there is only ipsilateral lower half of the face will be involved, whereas the eye
Yeah,
closure as well as the frontalis will be intact.
correct. But here some part is involved. No, it's not that it is
Lower part
normal.
lower part is involved, but upper part on the history we're not able to comment.
So in this case, it will be like UMN.
So history wise, it appears to be UMN.
And Sonal, the second thing you said, why you comment, why you think that it's an extra-axial lesion on the
So,
history basis of history? What are the points in favor of extra-axial lesion?
so most important is hearing loss points towards extra axial lesion.
Okay.
Why why you are concentrating only on the hearing loss?
So since it is one of the first symptoms that the patient complained along with headache, then this points towards an extra axial pathology.
So
No,
you
but
are basing it only on the basis of hearing loss that it is extraaxial.
yeah, that's a good question.
Unilateral hearing loss points towards an
How do
extra.
you how do you know whether it is cortical or it is peripheral?
Mhm. So cortical involvement, usually patients will have usually cortical bilateral involvement will be there. Unilateral involvement is unlikely.
No, but the hearing loss only on the hearing loss, what are the other things that you feel that it could be extraaxial? No, what you are asking is, you have said it is extraaxial. I am asking you why it is not intraaxial. Now let me put it the other way.
It's the same.
I say this is an intraaxial brainstem lesion. Can it be?
So intraaxial brainstem lesions usually present with the multiple cranial nerve involvements, and bilateral involvement will be there in intraaxial brainstem lesions.
Normally this patient sometimes you have intraaxial problem, walk straight to the OPD without any problem. But patient with extraaxial have multiple problems. You can make out once the patient comes to your OPD whether this patient is likely to have extraaxial or intraaxial problem just by the gait of the patient or the walk of the patient. So patient multiple bilateral, but what else? Multiple bilateral can be in extraaxial also. Can extraaxial also have multiple bilateral involvement?
Yes, sir. It can be possible in
For
case of
example,
chondromas.
this patient has got left-sided weakness and then followed by right-sided weakness also.
Hmm.
How do you explain that?
So it could be due to brainstem compression.
Compression. So brainstem compression should cause ipsilateral weakness. Or
Contralateral weakness.
where can brainstem compression, when does the brainstem compression cause ipsilateral weakness and contralateral weakness?
So, so usually compression from the ipsilateral side will cause contralateral weakness, whereas if there is like
No. Brainstem. I'm talking about brainstem. So midbrain, pons, medulla, right?
if the opposite side
When
of
you,
hmm,
yeah,
if the yes, if the
Sonal, please calm down first and then think that we are just talking between the difference between the intraaxial and extraaxial. Like, what are the points in favor of that? You first of all, you said that it's history suggestive extraaxial lesion.
yes,
That was the only question.
yes, sir.
So just calm down and relax,
yeah.
and then tell.
So, like in this
So
case,
what is the topography of corticospinal tract in the brainstem where it can produce ipsilateral weakness or it could produce contralateral weakness?
So ipsilateral weakness usually happens when there is contralateral weakness usually happens when there is compression of an extraaxial pathology from one side, whereas ipsilateral weakness can develop if the contralateral pathology pushes the brain, like the brainstem is compressed along on the opposite side at the tent margin. Then there can be
No, is it
ipsilateral
where does the pyramids decussate?
at the
You answer it now.
lower medulla, sir.
Then, what does is decussation of the pyramid has something to do with this ipsilateral and contralateral weakness?
So if the lesion is extending like beyond the foramen, like at the cervicomedullary junction, at that point, patients can have ipsilateral weakness.
Yeah. And how do you describe, differentiate this weakness from an upper motor neuron weakness? Suppose there is facial nerve palsy and weakness, right?
Yes, sir.
So how do you
Usually
differentiate
there
whether
will
it is upper motor neuron or it is supratemporal or infratemporal?
so there will be crossed paralysis in such case. Like
Yeah.
if it is above the decussation of pyramids, the facial palsy will be on one side, whereas the weakness will be on the contralateral side.
Correct. Yeah. So that is so the basic reason that we are asking you about intraaxial and extraaxial pathology is what are the things in intraaxial which will not be present in extraaxial? There are 2, 3, 4 factors which are there. Have you heard about medial longitudinal fascicle MLF? What
Yes.
does MLF do?
INO, the gaze
Will INO be there in extraaxial lesion?
less likely, sir. More common in intraaxial pathology.
Did you understand, Sonal? Did you understand what Dr. Dattatray asking?
Yes,
Did you
sir.
understood? Did you understood? No.
Yes, sir.
If you are not clear about the question, you can ask again.
Yes, sir.
So an MLF is the track which connects which nuclei?
So nuclear third and sixth, sir.
Yeah. So you know any of the syndromes which can be produced because of because of the INO, internuclear
Internuclear ophthalmoplegia.
Thermoplasia, yes.
So what are you have heard about 1.5 syndrome, you have heard about all those things, this
Yes.
third, fourth, sixth. So all this will not be produced by extraaxial, it will be produced by intraaxial. That is number one. Number two is what any autonomic involvement?
As
Horner,
in,
you heard about Horner syndrome?
yes, sir.
What is Horner syndrome?
So in Horner syndrome, patient will have ptosis, meiosis, along with the enophthalmos and reduced sweating over the face, sir.
So that will be produced in more likely in what kind of this thing, pathology?
Yes, intraaxial mode.
Intraaxial. And we discussed about the hemiplegia also, right?
Yes, sir.
So multiple bilateral involvement with internuclear ophthalmoplegia with Horner's usually will point towards an intraaxial.
Intraaxial.
Do you find this in this patient?
So bilateral corticospinal tract involvement is there, but
Okay. Now we come to bilateral involvement. So you said that initial unilateral involvement is because of the compression. Now, how do we explain the bilateral involvement?
So compression of the cerebral peduncle against opposite cerebral peduncle against the tent margin can present with ipsilateral, or if it is below, extending below near the cervico medullary junction, at that point also it
Usually,
patient will
usually does this give you an idea about the size of the tumor?
Yes, sir.
What
Means
does
the
it mean?
lesion is probably extending to above till the it is compressing the fifth cranial nerve above till reaching the Meckel's cave. Then inferiorly also it is extending, because lower cranial involvement is also there. It is extending till the probably till the foramen magnum. There is
So,
bilateral.
so here when we say that there is contralateral involvement, initially compression, but there is something like brainstem torsion, or it could be rotation. The tumor might be so big that sometimes this brainstem distortion, can cause contralateral. Now you are saying about it hitting the opposite, so that it is not like Carnot's notch that then that you're talking about a herniation case. This is not herniation we are talking about. We are talking about a chronic process where there could be rotation of the brainstem, or there could be a torsion of the brainstem, distortion. So that can produce this contralateral symptoms as well. Okay, understood.
Yes, sir.
So your answer that you are saying that it is hitting the peduncle is hitting, that is okay in the cerebral peduncle that we are talking about in the supratentorial. But that's more in acute subacute cases. When you are talking about such a this chronic case, then it has to be a large lesion where the brainstem tends to accommodate this and produce. You see what are the symptoms? You said it's from fifth nerve to lower cranial nerves, almost. Do you think that the shunt has made some difference in this BP shunt?
Sir, his complaint of raised ICP headache has reduced.
Yeah. So,
Other than that, the rest of the symptoms appears to be same after shunt.
so can the shunt also alter the history sometimes? His headaches have reduced, but his vision has not improved.
No, sir.
What is your idea about that?
Sir, by the time the shunt is done, probably the optic atrophy is already set in. That is why the vision has not improved.
Okay. So if a person is shunted, and I tell you that this patient has deteriorated or the symptoms have progressed,
Hmm.
can it happen?
Yes, the symptoms can still progress. Other than headaches, even vision can still deteriorate if the optic atrophy is already set in, despite the
No,
shunt.
no, no. Patient has got history for 7-8 months now, and there was had whatever raised pressure. Patient has been shunted. Now, whatever history he has had for 8 months,
Hmm.
now I'm saying in 15-20 days he has deteriorated further. Now you have done the shunt to relieve his headaches,
Hmm.
but his neurology has worsened further. So if that is the case,
Hmm.
what is your thinking in that point?
Means the lesion is large enough to cause other problems are more significant as compared to just the headache.
No, no, no. What has happened to I'm talking about the pathophysiology that is happening in that lesion. Something has changed. Has the shunt changed something?
So reverse herniation can occur.
So what can happen? So can you explain to me what do you mean by reverse herniation? What has gone wrong? What happens?
So all in reverse herniation, all the brain stems, like there is
Why there is reverse herniation? Why there is reverse herniation?
so because the posterior fossa is already very full, and the lower brainstem structures can herniate above because of the raised pressure in the posterior fossa.
No, but we are doing the shunt to reduce the raised intracranial pressure.
But sir, mostly it will only reduce the pressure in the bilateral lateral ventricles, whereas the fourth ventricle will already be collapsed because of the compression.
Then what happens?
Then
Something
the
must be happening, no? The tumor is the same, the brainstem is the same, but still there is what you call as reverse herniation. But something must be happening somewhere. That's why it is causing. No?
so because the lateral
Can the
ventricles, they will,
characteristic of the tumor change? Can the characteristic of the tumor change?
the lesion can bleed, sir, post shunt surgery.
Yeah. So you can say, that the tumor can hemorrhage inside, tumor can infarct inside. There could be increasing necrosis or something, degenerate cystic. Which are the patients?
Sticky.
Patient who has got more cystic tumors can bleed, cyst can increase. All the things there's a delicate balance between supratentorial and infratentorial system. Now you put a shunt, sometimes it can worsen the symptoms. So you have to understand that in this patient also, I think after the shunt has been put, the patient still progressed in the symptoms, as what I understand, isn't it? It could be a slow progression or a, a very catastrophic presentation as mentioned. So here now, what do you think the tumor is? Kind of what you are saying of extraction. What kind of tumor are you looking at?
Sonal, so what Dr. Dattatreya is asking is like in a 23-year-old male with 8 months history of lesion indicating towards the CP angle, what could be the first thing comes into your mind?
The first possibility I'd like to keep is as vestibular schwannoma,
Yes, very
then
good.
followed by trigeminal schwannoma.
And what are the incidents wise?
So hearing loss, like
No. Incidence of vestibular schwannoma in a CP angle lesion. If there are 100 lesions, how many times you can have
Incidence. What is the incidence? Percentage.
If there are 100 lesions you see in CP angle, how many could be vestibular? You get my point?
around 70%.
Which data, which statistics from which paper or which book you are quoting, Sonal?
Are you guessing? It is 70 or more?
Okay. On the other side, what Dr. Dattatreya is saying, what is the percentage of CP angle tumors came out as in a trigeminal schwannoma?
Percentage, I'm not sure.
What is the classical presentation of trigeminal schwannoma? Classical, you can see the patient and tell that this patient has got trigeminal schwannoma.
Patient will have temporal hollowing, jaw deviation, then difficulty in chewing food.
If it comes, then it is very late.
Yeah.
Then facial numbness can be present.
Initial symptom may be facial numbness. Yes, very good.
Facial numbness, headache.
And corneal, what about cornea?
Patient can complain of dryness of eyes because of
dryness.
As in foreign body-like sensation.
If the patient presents with trigeminal neuralgia, what is the most likely diagnosis?
That will be due to most commonly due to neurovascular conflict at root entry zone.
Tumor.
Tumor will be trigeminal schwannoma. I'd like to give as first possibility.
Trigeminal schwannoma will cause. That's the reason I was asking you. What is trigeminal neuralgia?
Because of the irritation of the trigeminal.
Irritation.
Then
So
meningioma.
now you have to tell me which tumors cause irritation.
Meningioma. Epidermoid.
Epidermoid is an irritative tumor, right? So you have to know this. This is how your differential diagnosis will work. So here you feel that facial nerve patient has got facial nerve presentation also. So why you are saying does vestibular schwannoma present with facial nerve? Even though they are large vestibular schwannoma, they don't present with facial nerve. And here you are saying here there is a facial nerve deviation which is seen.
Sir,
limb weakness, all these things.
Sir, cystic vestibular schwannomas can present with it is more associated with facial nerve involvement.
Okay, so cystic vestibular schwannomas with facial nerve involvement has a classical symptom or a sign. Now tell me, you have made, yeah, I understand. What kind of facial nerve involvement is seen in cystic vestibular schwannomas? Gold medal question. Is it facial deviation talking about? What are the components of facial nerve?
Like taste sensation, then this then facial motor,
Yeah,
and then sensor, this corneal reflex.
correct. So in cystic vestibular schwannomas, they present commonly with what symptom? Just as I told you, trigeminal neuralgia presents with epidermoid irritation, trigeminal neuralgia, most likely. See, we are talking about common sense. In similar way, cystic vestibular schwannoma, you said is facial nerve, agreed. But what kind of symptom? Now we say if this patient has got this, then this has to be this. Do the facial nerve schwannomas present with what kind of symptom? So facial nerve schwannomas also can be there, right?
Yes,
So
sir.
facial nerve schwannomas will present with what?
We can present with the facial motor.
Correct.
Facial
So
motor
facial
involvement
nerve
will be
schwannomas will present with facial motor.
motor involvement more.
Similarly, cystic vestibular schwannomas, if they have facial involvement, what kind of facial involvement is likely to happen?
Taste. Patient can
Taste
complain of
sensation.
taste.
So taste, when you have to check the taste, they will say that they have or not taste. Or there should be what it is known as, what is the medical term known for that?
Dysgeusia.
Oh,
Cystic vestibular schwannomas. What is the problem with cystic? What is the concern with cystic vestibular schwannomas?
So the facial nerve preservation rates are much less as compared to solid.
Facial preservation is difficult, yes.
Mm.
See, this
Then they
this vestibular schwannoma must be so huge. Still, the patient is, very well, kind of. He's not unconscious, right?
Sir, we'll have to proceed with the examination, sir.
Okay, chalo. I think we go with the examination. Dr. Prasanna? So, cystic vestibular schwannoma can have a short
Sorry. Should I proceed?
Yeah.
Yes, please.
On general examination, patient was conscious, cooperative, oriented to time, place, and person. He was thin built and malnourished with a BMI of 19 kg per meter square. There is no pallor, icterus, cyanosis or clubbing, lymphadenopathy or edema. Single breath count is 30 per minute. No neurocutaneous markers present. Pulse rate 72 per minute. Regular rhythm, normal volume and character with no radioradial and radiofemoral delay. Blood pressure is 110 by 76 millimeters of mercury. Right arm sitting, measured in right arm sitting position. Saturation is 100% on room air. Respiratory rate 14 per minute. Abdominal thoracic. Temperature is normal. Mini-mental state score examination, it is 26 out of 30. Examination of cranial nerves. There is normal bilateral perception of the smell. On cranial nerve 2, there is PL positive both eyes with bilateral secondary optic atrophy. Pupillary reflexes were intact. On third, fifth, fourth, and sixth, there is normal extraocular movement with no ptosis. On fifth nerve examination, there is left side the temporal hollowing present with decreased bulk of left masseter on clenching the jaw, deviation of jaw to the left side on opening the mouth, and there is weak hold of tongue depressor by left molar teeth. Sensation, it is decreased in 3 V1, V2, and V3 distribution. Right side on corneal reflex, right side direct corneal reflex is present. Conjunctional is absent. On left side, direct and conjunctional reflex both were absent. Jaw reflex is absent. On seventh nerve examination, there were no fasciculations and there were no wrinkles on left side. Left nasolabial fold is obliterated. There is grade 3 House-Brackman element palsy and the taste left side is decreased. On eighth nerve examination, there is no wax present, no discharge from the ear or no vesicles over the ear, no mastoid tenderness present. Finger rub, he could not appreciate from left ear. On tuning fork test, Rennie's bilateral hair conduction more than bore conduction but decreased over the left ear. Weber's test lateralized to the right ear. Absolute bone conduction, it is decreased in left ear as compared to the examiner. Brunt's nystagmus is present. Pass pointing is impaired. Tandem walking, Romberg and star work could not be performed. On 9th and 10th examination, ULI is deviated to the right side. Left side gag is absent. Right side it's weak. Weak coughing is present. And there is nasal fang of the voice. On 11th of examination, left side sternocleidomastoid atrophy and no fasciculations were present. There is drooping of the left side shoulder present. And left side sternocleidomastoid and trapezius were weak. On 12th of examination, there was no fasciculations present, no tongue deviation present, no atrophy or weakness of the tongue present. On motor examination, bulk is equal on both sides. On tone, modified Ashworth grade 2 in all 4 limbs. Power, it is on left side more than right side. Weakness is present with 3/5 power in left side and 4 minus by 5 in right side. Reflexes are pectoral present in both sides with exaggerated reflexes, and Hoffman is absent in both sides. Superficial abdominal and cremastic reflex are diminished on both sides. Sensory system, touch, pressure, proprioception, vibration, and pain sensation perceived normally all over the body except over the face. And cerebellar system, titubations were present. Dysarthria and scanning speech was present. Nystagmus, Brunson nystagmus is present with coarse component towards the left side and fine component towards the right side. Intentional tremors were present. Fine motor skills were impaired. Finger nose and finger could not perform. Heel chin test was impaired on both sides. Dystachyokinesia was impaired. Spine examination is normal. There were no signs of meningeal irritation. Other systemic examination is normal. Summarize. My patient is a 23-year-old male with left side cerebellopontine angle lesion. Surgery post left side defusion with features of bilateral second, left fifth, seventh UMN, eighth retrocochlear sensorineural hearing loss, 9th, 10th, and 11th cranial nerve involvement with middle cerebellar peduncle and cerebellar involvement, and both corticospinal tract left more than right side UMN involvement with features of raised ICP and no sensory or autonomic involvement.
So your Prasanna, your provisional diagnosis is?
My first provisional diagnosis would be a vestibular schwannoma.
Okay. Then
Then it could meningioma or then it could be a meningioma, but meningioma usually presents the hearing loss and cranial nerve deficits in the later stage, and it could be epidermoid, but it most commonly presents with features of trigeminal irritation, and it could be an arachnoid cyst or trigeminal schwannoma or lower cranial nerve schwannomas. But my most first provisional diagnosis would be vestibular schwannoma.
there is no neurocutaneous markers.
No, sir.
So still you want to think the same thing, or you want to change some? In a 23-year male, CPN with so much of problems, still you will think vestibular schwannoma is so common in young males with no neurocutaneous markers?
Based on the presentation of hearing loss first, I would think a lesion which was probably arising from the vestibular nerve.
So Sonal, what are the other causes of hearing loss in 23-year young male with no neurocutaneous marker and multiple involvement with the VP shunt was already put in?
Because in after vestibular schwannoma, the next second possibility I'd like to keep as trigeminal schwannoma. After that, maybe meningioma, because in this age group, meningioma is unlikely. Epidermoid as last possibility, since epidermoid usually does not present with raised ICP features.
Wait. Now, can this patient have only raised intracranial pressure, hydrocephalus, and no signs of posterior fossa, but still there could be a posterior fossa tumor? I mean to say that you said that epidermoid doesn't produce raised ICP. You said
Unlikely.
that, right? Just now.
Unlikely.
So I'm asking you Can patient present only with raised ICP with no posterior fossa signs, then what is your likely diagnosis? And I'm telling you that patient has got posterior fossa problem. What
No,
is
no posterior fossa. Sorry, sir, can you repeat the question?
I'm saying that patient has got raised intracranial pressure.
Yes, sir.
Okay,
Hmm.
no posterior fossa signs.
Hmm.
Still, the patient has got a posterior fossa pathology. If so, then what it could be most likely?
If there are no, so in that case, epidermoid might be a possibility. If raised
So
ICP
the
is there,
earlier,
but if
so the
no
earliest sign we say trigeminal neuralgia can be an epidermoid,
Hmm.
but sometimes epidermoid can be so silent that
Hmm.
they can you assume huge proportions and they can go into the crevices, block the CSF spaces, and they present as hydrocephalus. So they could present as headache, ataxia, and still that could, if you scan them, sometimes they have got huge epidermoid in the posterior fossa. It could be a posterior fossa epidermoid,
Hmm.
midline epidermoid. We never know. So in this case, two things I wanted to ask you clinically compared to this. So how does Bruns nystagmus differ from other nystagmus? Why we say there is a Bruns nystagmus in CP angle?
So in Bruns nystagmus, there will be ipsilateral coarse nystagmus due to ipsilateral cerebellar involvement. And that is on looking towards the side of the lesion, the patient will have ipsilateral fast component with coarse, high amplitude nystagmus and low frequency. And on the contralateral side, because of contralateral vestibular involvement, there will be contralateral fine, low amplitude, um, uh, mm, low amplitude, high frequency nystagmus with the fast components on component towards the opposite side.
How does it differ from other nystagmus? Normally,
Hmm.
the slow component in an nystagmus points towards what? See, we are talking about an nystagmus very specific, localized to vestibular schwannoma when it was discovered by, who was Bruns, by the way? You need to know, you might be interested in knowing this. Okay, he was an American physician. So it was being discovered by an American physician. So normally when we have nystagmus, the slow component of the nystagmus is the side of the pathology usually. Okay, you say that here the ipsilateral on the side of the lesion, it is a coarse nystagmus, high amplitude. So that differentiates Bruns nystagmus from rest of the nystagmus. You understood? Here we are saying ipsilateral fast, coarse, high amplitude, which is present specifically in Bruns. In other nystagmuses, where there are other lesions, the side of the pathology, there is a slow component, and the fast component is the corrective component. You understood? You might read it later on. Okay. And second thing is, what do you think is the cause of ataxia in this patient?
Sir, in this patient, the ataxia could be due to cerebellar compression or middle cerebral peduncle compression.
Cerebellar or middle cerebellar?
So,
Or both?
MCP, since he has both upper limb and lower limb involvement, MCP is a possibility. Middle cerebral peduncle involvement.
In extraxial component, it is the middle cerebral peduncle which is causes ataxia. Is the peduncle joins the cerebellum to the brainstem. Okay, so that is the cause. You see many cerebellar tumors patient walking in the OPD without any ataxia. Have you seen patients doing normal, but patient you scan and they show a cerebellar tumor? Cerebellar.
Yes, sir.
Here the predominant issue of ataxia is primarily because of the MCP component. These things have to be understood. Any other question, Dr. Mansal, that we go to for the investigation? We have the scan here. Scans are there.
Yeah, we have scan.
Yes, sir.
Yeah, so what do you want to do now?
We will ask the Sonal what kind of scan should be your first choice. What do you want?
So first, I'd like to evaluate the patient with MRI.
Why not CT?
So because I'm it's an intracranial pathology. So first thing I'd like to do is an MRI.
So you know the patient has already underwent VP shunt. So the CT scan would have been done at that time. You don't want to see that scan?
Yes, sir, I'd like to see that as well.
So did you forget that?
What we will come to what is the importance of CT in this case. So now if you say MRI, you have the MRI here?
Yeah, we have
Yes,
MRI
sir.
also, we have CT scan also. But
Yeah.
why not CT? I'm asking Sonal. Why not CT?
So CT also I'd like to do, but first usually the investigation of choice is MRI to see the characteristic and extent of lesion. That is
No,
better seen on an MRI.
no, that is true. But patient has already underwent VP shunt. So CT scan was done at that time. Have you seen that CT scan?
I have not seen, sir. I have not seen, sir.
So, Prasanna, do you have that CT scan?
During that P patient surgery, that film is not
What is
available.
Yeah,
That
yeah.
CT is
What is
not
your
available, sir.
CT
But
now?
current CT is there.
Before
So
VP shunt
Sonal,
was done.
what
No, sir. That film is not available
Okay.
with him.
So what is
Okay.
the CT showing here now, Sonal? What is the CT showing here?
So in this image, we can see that the left side internal acoustic meatus is dilated. There is like lesion is not, it is iso
It
dense
is not
lesion,
dilated. You should use the correct words.
widened, sir, widened.
IAM is widened.
Widened.
Okay. Then,
Other than that, sir, there
then
is isodense lesion in the left CP angle, but brainstem, the margin between the brainstem and the lesion is not very well seen on the CT scan.
Cannot be differentiated.
We can, yes.
what other, now since we are on the CT,
There is no CP angle cistern is seen. There is no CSF
yeah,
cistern is seen anywhere. And but there is one hypodense or cystic lesion seen in the left middle temporal area. Can you see that?
Yes, sir.
It's there also on the right also, but left one is bigger in the area of just above the Gasserian ganglion area. Maybe you can say Meckel's cave.
Yes,
yeah.
sir.
So why it is seen the cystic lesion there?
So usually in case of extraaxial pathologies, the cisterns on the ipsilateral side will appear more dilated.
No, but the lesion is here in the CP angle. There is no CSF seen at all. Medial to tumor or anywhere. So anyway, we'll see it later. So now you are asking for the MRI scan, right?
Yeah, any other thing you are now we should see on the CT. Any other things are important on the CT?
So other things that we see on CTs, one is the pneumatization of mastoid we have to see.
Yeah.
Then we can look for any high riding jugular bulb. Then the confirmation of widening of internal acoustic meatus.
Can you see the VP shunt tube here in the CT scan?
Uh, yes, sir. It can be seen right
Which side?
on the left side only it is there, sir.
So the person who has done the VP shunt, he was knowing that there is a lesion on the left side and he did the shunt on the left side. Why on the left side? Was he right or wrong?
I believe, sir, should have been done on the opposite side.
So this is not good.
So, no.
Hmm? Yes, yes. Speak. Don't worry. This is yes. You are absolutely right. Don't hesitate.
So it should have been done on the right side so that if we want to approach the lesion, if it is a posterior fossa lesion, if you want to approach through retromastoid approach, then in this case, craniotomy will be difficult
So
because
why
the
he
shunt
has,
will be in the way.
why he has done on the left side? The problem may be because he is a very poor, he must have done the CT scan of first generation or second generation where the lesion could not have seen. He could have seen only hydrocephalus, and he just have put the shunt only
He must have put the shunt without thinking that there is a lesion.
without thinking of the lesion, maybe somewhere in the periphery. That's why the first CT scan is not available with Prasanna, I think. Right, Prasanna?
No, sir, it's not available. Correct.
Yeah. So now you want MRI, Prasanna? Can you show the MR? What kind of MR sequence first of all you want, Sonal?
So T1, T2, flare and contrast imaging.
So you have all the three images here.
Sorry to interrupt. We'll have to finish the case soon because we have the next case and then the
Yes.
hosties also.
Okay, Prashant. Thank you.
So you can you see here what is the I was talking about brainstem distortion.
Yes, sir. Yes, sir.
So now what is this tumor and how will you approach?
So this is it's a well-defined extra-axial lesion in the left CP angle extending into the left internal acoustic meatus, causing widening of the IAM. Just T2 hyper-intense with few heterogeneously hyper-intense with few areas of
What is
hyperintensity.
the diagnosis?
It's a vestibular schwannoma.
Now how will you approach this?
Sir, in this case, patient already has hearing loss and it's a large lesion mainly in the posterior fossa. So we can approach it by retromastoid suboccipital
What is the
craniotomy.
goal of surgery?
Goal of surgery is decompression of the lesion to relieve brainstem compression.
And
So CSF pathway can also be opened.
okay. Facial preservation, already the facial is affected.
So facial preservation is also possible. A part of the lesion that is along the facial nerve route that we can leave behind, that can be later treated with.
What position will you do with this in?
Sir, lateral position with head in anti-flexion,
Which other
lateral
position
flexion.
do you know? Which other position do you know of?
In park bench position also it can be operated.
Any other position which is not favored by everybody?
So sometimes we will do it in supine position also, but
Okay,
rotation
supine
is
with head turn. Any other position? You are not talking the hot position, which is a controversy in these patients. Have you seen this patient been done in sitting position?
I've heard but not seen.
What is the problem with sitting position?
So there is risk of air embolism.
Okay. So how do you monitor? Have you seen any anytime sitting position?
Sorry, I have not seen.
Okay.
Not myself, but in other
Okay.
OTs.
What are the problems of this surgery now? Post-operatively.
So post-operatively, since the patient already has lower cranial involvement, so patient might require prolonged nasogastric tube feeding. He might also require PEG if the lower cranial function does not improve. Then he may require prolonged ventilation as well, since already significant brainstem compression is there. Then for residual lesion, since we might not be able to remove the entire tumor, he will require gamma knife therapy later.
Why gamma knife?
Like for facial preservation, we'll have to leave some residue.
Okay, so what is the cutoff of gamma knife?
Usually, sorry, they're less than 3 centimeters or less than 10 to 12 cc.
Okay. Okay. And how will you follow up this patient?
So follow up with the sequential MRIs every 3 to 6 months.
Okay. And you have to counsel. What counseling will you do for these patients? They have come with so many symptoms. So,
So the weakness and the ataxia that is there, usually it may worsen post-surgery, but it takes time for that to improve.
what about hearing?
Hearing, sir, since already the hearing patient already has hearing loss, so that is less likely to improve.
Okay. Fine. I think Dr. Bansal, you want to ask
Yes.
something final?
No, we can proceed for the next case. I think the time is already very constrained.
Okay.
Now, Sonal, you will present the next case?
Yes, sir.
Dr.
Okay.
Sonal, you can present your case. You can share your screen.
This is how many minutes?
Sir, 40 minutes, sir. Then off keys are there.
We have already 20 minutes.
Okay.
No problem, sir. Dr. Sonal, you can share your
Yes.
screen with slideshow.
Yes, sir.
Sonal, you are going to present the case of peripheral now? Something?
Yes, sir. Okay. So is it visible, sir?
Yes.
So this patient is a 27-year-old male from West Bengal, Bengali and Hindi speaking, class 10th educated, a daily wage laborer, right-handed, unmarried, informant is self and history is reliable. This patient presented with alleged history of RTA two-wheeler rider hit against a lamp post on 27th of March 2025. Following that, the patient presented with complaint of weakness of right shoulder and arm since then, reduced sensation over the right shoulder, arm and forearm since then, and progressive thinning of the right shoulder and arm since then. The history of presenting illness, this 27-year-old male was apparently all right till March 2025 when he had an alleged history of RTA, two-wheeler hit against a lamp post on 27th of March at 11 p.m. Near Orissa. He hit his right shoulder against the lamp and against the lamp post and fell down following the accident. Following this injury, patient had a loss of consciousness for less than 30 minutes and was taken to a hospital nearby. Now, on gaining consciousness, he noticed that he was not able to lift his right arm. So, hmm, 1 second, sir. Yeah. On gaining consciousness, he noticed that he was not able to lift his right arm above his shoulder. He reported severe pain in the front of his right shoulder with painful movement of the right shoulder when examined by a doctor. Similarly, he also reported pain in the right wrist with painful movement of the right wrist. He was evaluated and diagnosed with a fracture of the right clavicle and right wrist, that is distal radius fracture, and he underwent open reduction internal fixation for clavicle fracture on 31st of March, followed by a radius fracture on 1st of April. Now he was kept on post-op care in hospital with splinting of the shoulder as well as wrist following surgery for a period of around 20 days. During this time, he was able to move his fingers during this and had no difficulty in holding small objects in hand or appreciating the temperature of water or any tingling or had any complaint of tingling or numbness over the fingers. After removal of the splint after 20 days, he noticed that he had developed weakness of right shoulder and arm. A patient reported difficulty on the right side in moving the arm above the shoulder, in bringing the food or glass to the mouth, wearing a t-shirt or to negotiate arms into sleeves, to bring the mobile phone to his ear to talk to people, or combing or shampooing his hair and swinging the arm while walking. However, the patient did not report any difficulty on the right side in making a bolus of food, holding a mobile phone and using the mobile phone in hand, any making of fist, any holding railings or objects tightly in hand, or opening bottle caps or using a lock and key. Now, this weakness was maximum. Yeah, this weakness was maximum when he noticed it and had not improved and worsened since this time. He also noticed that his arm was hanging down loosely by the side. He does not report any tightness of shoulder or arm or any painful restriction of movement of the shoulder or elbow. Now, also noticed that he had reduced sensations over his right shoulder, right arm over the outer aspect, and right forearm over the outer aspect. He was not able to feel the t-shirt or shirt over this region. He was not able to feel his hand over this region while taking a bath. He was not able to appreciate the temperature of bath water over this region. This was maximum when he noticed it for the first time and has been the same since then. He does not report any tingling sensation or pain in this region. He has also noticed progressive thinning of his right shoulder and arm. He noticed that his shoulder has become flat on the right side as compared to the left. He also noticed thinning of his right arm, which is progressively worsening since then. However, the patient does not report any abnormal flickering or twitching movement over the limbs or shoulder. He was started on physiotherapy for the same after this and has not reported any improvement in weakness, thinning, or numbness. Now, there is no history of any neck pain, any radiating shock like pain, weakness or thinning of forearm or hand, any weakness of other limbs, tightness of other limbs, reduced sensation over other limbs, any bowel bladder disturbances, any painful neck movements or restriction of neck movements, any difficulty in breathing, drooping of eyelid, any double vision, any reduced sweating over the face, any painful shoulder movement, skin changes over limbs or pale limb, any blackish discoloration over fingers or thumb, any wound discharge through clavicular or radius fracture sites. Past history, the patient has undergone open reduction internal fixation for clavicle fracture and radius fracture. There is no history of hypertension, diabetes, TB or TB contact, hypothyroidism, drug allergies, or any other prior surgeries. Patient reports taking occasional alcohol once a week and denies other addictions. Bowel bladder habits are normal. Sleep is normal. He's on mixed diet. Family history is insignificant. Treatment history is not on any other medication. Now, summarizing, this 27-year-old male presented with alleged history of RTA on 27th of March 2025 with fracture of right clavicle and acute onset element type of weakness of right shoulder abduction and elbow flexion associated with complete sensory loss to touch, pain and temperature along the right C5 and C6 dermatomes. So, analyzing patient present with shoulder abduction weakness, suggesting towards supraspinatus and deltoid weakness, that is suprascapular and axillary nerve. Elbow flexion weakness, pointing towards biceps brachii, coracobrachialis, and brachialis weakness, pointing towards the musculocutaneous nerve, and the sensory loss along the lateral aspect of arm and forearm, pointing towards the areas innervated by C5 and C6 dermatomes. So, analyzing localization, post-traumatic weakness of right shoulder abduction and elbow flexion, pointing towards brachial plexus injury and history of right clavicular fracture. The root value is C5, C6 in view of the muscles involved, and pointing towards upper trunk injury, most likely postganglionic. The points favoring towards postganglionic being clavicular fracture. So possibilities I've kept as upper trunk brachial plexus injury at C5, C6 level, postganglionic more than preganglionic.
So, Prasanna, what do you think about this case?
So he most likely sustained due to trauma and due to the clavicular fracture, he most likely had partial brachial plexus injury. Based on the sensory and motor distribution, it is most likely localizing at C5 to C6 region in the upper trunk.
Okay. So why, just for my this thing, why this cannot be a cervical spine injury?
So he is having wasting and also fasciculations over the right side shoulder, which is pointing towards the element sensor. He is not having any spasticity, which is opposite to the human side.
Okay. So we are on the history only, right? Here, still exam. We have done the entire thing now, or we are just on the history?
Only on the history, sir. Examination is still pending.
Yeah, okay. So here you, based on the history, you feel that since there is no spasticity, It is unlikely to be a C-spine problem. That's what you
Yes,
need.
sir.
Okay.
Yes, sir.
Prasanna, did she left something in the history? Do you want to ask some more? Which she could have left?
Any current like sensations present over the
Hmm?
No
any
radicular
current like
pain.
sensation?
Had she completed the history or something she has left? Do you want to have, if you would have taken this case, did you took more history? Will you ask something more, or is it okay? Hmm? So now, should we proceed with the
Yeah.
examination?
Yeah. Go with the exam.
Okay. Hmm?
Examination, general physical examination. Patient is moderately built, well nourished, vitals, temperature febrile, heart rate 80 beats per minute, regular rhythm, left radial artery in sitting position. BP is 118 by 70 mmHg in left brachial artery in sitting position. Respiratory rate is 14 per minute. No pallor, icterus, clubbing, cyanosis, lymphadenopathy or petal edema are noted.
नहीं मैं बोल रहा हूँ ना इसी को डालो 1 लाख सीधा निकलेगा
Respiratory system. Patient has bilateral air entry equal. Normal vesicular bed sounds heard bilaterally with no added sound. SBC is 45. CVS examination S1 S2 heard, no murmur. Per abdominal examination is soft, non-tender, no organomegaly. Bowel sounds heard. No neurocutaneous markers seen. Clavicular and wrist wounds are healthy. CNS examination, high mental function. Patient is conscious, obeying all commands, well oriented to time, place, and person. Memory, immediate, recent, remote, intact. Attention normal, calculation is normal, comprehension intact, and speech is normal. Cranial nerve examination, cranial nerve first. Normal sense of smell noted bilaterally. Visual acuity bilateral 6/6. Visual field is normal on confrontation test. Fundus is bilaterally normal. Pupillary reflex bilateral directed conceptual present. Accommodation is present. Third, fourth, sixth cranial examination. No ptosis, exotropia or esotropia. Extraocular movements, normal range of movement noted in all gazes. No diplopia and nystagmus. Pupil bilateral directed conceptual present. Accommodation is present. Fifth
Just tell
cranial
only the positive findings first. Only positive findings other than this.
in cranial of 11th examination, sternocleidomastoid and trapezius is normal. Motor examination or inspection, as seen in the image, there is healthy scar noted of the right clavicular wound. Other than that, patient has right arm is hanging loosely at the side, with there is loss of right shoulder contour as compared to the left, and there is also drooping of the right shoulder noted. There in the right supraclavicular operative site, there is no fullness or redness or erythema or edema noted. There is atrophy of the right deltopectoral region noted with atrophy of the right arm and forearm. Then from examination from behind shows prominence of the spine of scapula with atrophy of the supraspinatus and infraspinatus muscle. And visible fasciculations were noted on the right deltoid. On palpation, there is no tenderness noted in the supraclavicular fossa or right shoulder. On bulk examination, there is loss of right shoulder contour with drooping of right shoulder, atrophy of the right deltopectoral region, atrophy of the right arm and forearm. However, there is no hypothenar or thenar wasting noted and no clawing of hands noted. On measurement, the arm circumference on the right side is 16 centimeters and left side is 22 centimeters, 15 centimeters above the olecranon process, and in the forearm it is 18 centimeter and 20 on the right side and 20 centimeter on the left side. That is around 12 centimeters below the olecranon process. That is significant atrophies noted both in the right arm and forearm. On tone examination, there is reduced tone across the right shoulder and elbow joint noted. However, the tone distally in the wrist is normal, and rest of the limbs tone is normal. On motor system examination, on rhomboids major and minor, that is there is right side is 4/5 and left side is 5/5. That is intact. In levator scapulae, also the power is intact bilaterally. In supraspinatus, on shoulder abduction, on the left side it is normal, whereas on the right side the patient was not able to start abduction. Infraspinatus, there is external rotation. On the left side, it is normal, whereas on the right side, patient was not able to perform. Serratus anterior, on trying to push the examiner's hand, left side is 5/5, whereas right side also, it is preserved, it is 4/5. Subscapularis, on the left side, it was normal, whereas on the right side, patient was not able to do it, was 0/5. In teres major, on the left side, it was normal, right side also, it was intact, was 4-5. Latissimus dorsi was also normal bilaterally. Pectoralis major was also, right side was 4/5 and left side was 5/5. Coracobrachialis, elbow flexion was noted to be 0/5 on right side, whereas 5/5 on left side. Deltoid, the left side it was 5/5, whereas on the right side, patient was not able to abduct. Teres minor, also patient had 0/5 on external rotation, whereas left side was 5/5. Triceps brachii, right side was 4-5 and left side was 5/5. And supination was also, left side was 5/5 and right side was 4-5. Pronation on the right side was 4/5 and left side was 5/5. The rest of the muscle examination, brachioradialis was 3/5 and on the right side, and extensor carpi radialis, longus and brevis was 4/5. However, rest of the motor system examination, distally was normal. Lower limb also power was 5/5 in all across all joints. Cerebral system, speech was normal, no truncal ataxia noted, no nystagmus, tandem gait was intact. On the right side, finger nose test and finger test could not be tested, and dysautokinesia and Holmes rebound phenomenon could also not be tested, whereas on the left side it was normal. On sensory system examination, in the right C5 and C6 dermatome, 80% sensory loss was noted to touch, pain, and temperature, and rest of the it was normal in the rest of the dermatomes. Perianal sensations were intact. In posterior column examination, vibration proprioception was bilaterally normal, Romberg's test was negative, and superficial reflexes, bilateral abdominal reflexes were present, and plantars were bilaterally flexor. On deep tendon reflex examination, pectoralis jerk was the biceps supinator and triceps was reduced on the right side and normal on the left side, and lower limb reflexes were normal. Hoffman's was negative bilaterally. Gait and stance, on walking, the patient's right arm was hanging by the side, adducted and internally rotated, and right forearm was extended and pronated. On walking, his arm was held closely to the body with no arms being noted on the right side. So in analysis, the muscles involved include supraspinatus and infraspinatus, that is supplied by the suprascapular nerve, C5, C6 dermatome. Then deltoid, that is supplied by the axillary nerve and C5, C6 root value. Then the clavicular head of the pectoralis major, supplied by the lateral pectoral nerve, C5, C6 root value. And elbow flexors, that is biceps coracobrachialis, supplied by the musculocutaneous nerve, as well as the wrist extensors and brachioradialis, also supplied by the C5, C6 root value. On sensory, the sensory loss is noted in the lateral aspect of arm and forearm in the C5, C6 dermatomes. The reflexes involved mainly include biceps and supinator, also C5, C6 root value. However, the muscles that are spared include the levator scapulae, rhomboids, supplied by dorsal scapular, and serratus anterior, supplied by long thoracic nerve, and also the muscles supplied by the C7, C8, and D1 dermatomes, that is distally. So the substrate involved at the end of examination, I'd like to keep as C5, C6 myotomes and dermatomes distal to the origin of the nerves arising from C5, C6 and dorsal anterior MI, that is a sparing of dorsal scapular nerve and long thoracic nerve noted, and proximal to the origin of the supraspinatus nerve, that is upper trunk of the brachial plexus. So localization I've kept as upper trunk of brachial plexus. Should I go with the NCS examination or?
Oh, well, very. We just want to ask this now. Any other 2 points in the history which and or in the exam which are not mentioned? Extensively, you have told about the exam. Two points. Have you talked about respiration?
Yes, sir, I mentioned, sir. SBC was 45 and respirate, and other than that, bilateral normal vesicular breath sounds were heard.
Prasanna can ask.
Respiration. Yeah.
Tinel sign or
So the problem
Lermit
is
sign?
no. If there is a problem with respiration, then where is the lesion? What is that?
So then, there's in phrenic nerve involvement C3 to C5.
And you didn't mention about Horner syndrome?
Yes, sir, I've mentioned, sir.
I didn't see probably. If the Horner syndrome is present, then where is the lesion?
Then the lesion, then it will be involving the lower part of the brachial plexus, sir.
Which?
So C8 T1, sir.
So T1 will cause this thing. So that so here now what are we looking? The weakness has been noticed after the fractures have been fixed, right? Is that the story? Is that the story, right? The weakness was there, but it became more pronounced after the splint was removed, isn't it?
So as in he noticed more after the splint was removed.
Yeah, okay. So what do we, Dr. Bansal, do you want to ask any clinical question or we go for the exam? Is he there? Okay.
First, we should ask Prasanna if she has left anything. Sonal has left anything. Prasanna,
Do you think you missed anything?
has she left anything in exams, or do you want more, or is it all right? You go ahead with the investigation.
Sir, regarding Tinel sign and Lermit sign.
Okay. Okay, what was that, Sonal?
Then if we are expecting any peripheral nerve pathology, then in that case, Tinel sign can be tested. That is tapping of the nerve at the wherever it is superficial, so that in that region the patient can have paresthesias.
And Lermit sign?
Lermit sign, we ask the patient to bend the neck forwards. So if there is compression over the posterior column, then the patient can have paresthesias involving all four limbs.
You have asked it in the exam. You checked it in exam.
In examination, I've not mentioned.
Okay. Anything else? Good. No problem. You have done the examination thoroughly. Now, what is the other possibilities? What investigation you want Prasanna now? Ask her.
Nerve conduction studies and electromyography studies.
Have you done that?
And an MRI of
MRI to rule out what?
rule out brachial plexus injuries.
How will it look like?
Or any other lesion
Before we see the MRI, what will the MRI show?
Which MRI you will want? Which kind of MRI? What region of MRI? What you order in MRI?
MRI of the
Yes, please come, please.
MRI of the shoulder, including the neck region to look for the brachial plexus and
Which sequence is the best sequence to find out the?
Cis sequence is the
Okay, Sonal, do you know what are the good sequences to look for the brachial plexus injury?
So we can do stir sequences.
Very good. Basic images where you have, if you are sitting in a periphery and you have 0.2 Tesla MR.
T1. T1.
T1 space is another sequence that we can do.
What you are going to look for?
Any or any lesions present surrounding the nerve.
Okay, Sonal, is
Sir,
it okay?
What are you going to look on MRI? That's what we're
on
asking.
on MRI, first we'll look for if there is any root avulsion noted along the cord. Then we can look for any pseudocyst formation or any neuroma formation can be seen on MRI. Then the extent of discontinuity of the along the nerve roots can be seen.
Okay. Do you have the NCV studies?
Yes, sir.
What does it show?
So on NCS studies, first motor conduction studies showed normal distal latencies and conduction velocities and CMAPs of bilateral median, ulnar and radial nerves with normal F wave latencies and persistence was noted. And however, absent CMAPs was noted in the right deltoid and biceps, as it can be seen in this image. The D1, it shows right deltoid has absent CMAPs. Then on sensory conduction studies, there were normal latencies, conduction velocities, and snap amplitudes of bilateral median, ulnar, and radial nerves were noted. And even the snaps of lateral antebrachial cutaneous and medial antebrachial cutaneous nerves were bilaterally present. So on this impression, the right axillary and musculocutaneous nerve involvement was noted, that is C5, C6 nerve root. And in view of preserved snaps, it points towards preganglionic injury. But
Okay. Fine. And what about the MRI?
yes, sir. Actually, MRI was also done for the patient. So there is all the roots appears to be there is no root avulsion noted on either side. However, because the patient has right side clavicular implant, that's why it was not possible to visualize it beyond clavicle. Till clavicle, there appears to be no signal changes in the in any of the roots. No pseudocyst formation noted. No signal intensity changes noted on MRI.
So, Prasanna, are you happy with the MRI and this thing, or you want more something?
MRI, it is not properly visible, sir.
But because of the clavicular implant, they can't do the MRI, right? Properly.
Yes, sir.
What? How would you like to go about this case now?
The orthopedician who has fixed the clavicle in the beginning has not thought about that there could be an underlying brachial plexus injury.
No, sir. At that point, they did not think. Only after the splint was removed, they found out that patient has weakness.
Yeah, that was the weakness before which was missed.
Yeah.
Yeah.
Oh.
So how are you going to approach this case now, Prasanna? What do you want to do? And what can we offer to this patient now?
So nerve graft transfers can be offered for this patient, sir. If the symptoms are persisting, if early, we can go for this nerve graft transfers.
What
For
is
how
the
long you're going?
Yeah.
How long you're going to wait?
Time 6 months,
Yeah.
I think, sir. I'm not
And why
sure.
do you wait actually? Why do you wait?
For the regeneration of the nerve, peripheral nerve have a capacity to
How
regenerate,
much
so
time do you
we
give
wait
for
for regeneration.
how much time do you give for the nerve to recover?
Approximate 3 to 6 months it takes for a nerve to recover. If
So
no
would you wait
recovery, then we go for surgical
so would you wait
exploration.
for 6 months or 6 weeks or 6 months? What would you
3
say?
months you should.
Yeah.
3 months we can do, and then we look for improvement. If no improvement, then we can go for surgeries.
So what kind of nerve transfer can you offer this patient? He has a 6356, right? Now.
Yes, sir. Sural nerve graft transfers can be done for muscular cutaneous nerve, and spinal accessory can also be done, sir. And
What are the names of the procedure?
or
The procedure is named after something.
To which nerve?
Which to which
sural
nerve?
Sural nerve to
muscular
which nerve?
cutaneous nerves and
At what
sural.
level?
C5 at the clavicle.
Could we find out the lesion away from where the nerve is cut up?
Spinal accessory and on MRI we can see the where the nerve grafting just beneath the clavicle where the fracture site is.
What is Oberlin's procedure?
Where we try to join the nerve tube of both the cut ends.
Where to where?
From the proximal to the distal, if it is possible, then we try to join the nerves. If it is not possible, and if it is more than 1 centimeter, then we can go for direct nerve graft transfer.
No, so Oberlin's procedure is transfer from which fascicles to which fascicles?
Ulnar nerve to
Ulnar nerve to? So we normally upper trunk palsy sometimes we do, right? Ulnar nerve to musculocutaneous.
musculocutaneous. Yes.
Yeah. Okay.
Hmm.
Anything else? What is the prognosis? What is the prognosis of this patient? How do the patient will ask? You are doctor, you are doing the procedure, but what is the outcome?
Post the nerve graft, then we can go for again these nerve conduction studies, and then we look for improvements if
After how much
the
time?
nerve graft is successful.
After how much time?
Again, 3 to 4 months. 3 to 4 months post.
And suppose that doesn't give you any satisfactory result, then what is the option?
Physiotherapy and counseling with the patient.
Sonal, anything you want to add? If suppose the nerve transfer doesn't take up, then what is any other options are there?
The tendon transfer can be done.
So which other specialty would be probably involved in this?
Orthopedics.
Or plastic surgery?
Plastic surgery.
If nerve transfer doesn't work, then he's a young guy. He may be a productive person in the family, and it's the right hand.
She said about tendon transfer, but anything?
Somebody write stimulation.
Yeah, stimulation. Anything? Any minimally invasive techniques or any would you ask for any other kind of modality? Nerve transfer, tendon transfer is done. What are the other alternatives which may or may not work, but we can hear. Prasanna, you mute.
No, sir.
Any stimulation techniques are there? There's somebody has written stimulation in the chat box.
Nerve stimulation can be.
Yeah, okay.
Or muscle transfers and.
Yeah, so we do muscle transfer, tendon transfers, maybe stimulations, but obviously we'll have to explain the prognosis to the patient. In these patients, the most important thing is that the patient has to know beforehand. They have to be counseled about the worst outcome, because if suppose things do not work, then they might ask you that, doctor, why have you done the surgery if you are not sure about the result? Okay. So you have to counseling is most important in these patients. Okay, I think Dr. Bansal, anything more or we?
No, this is good. This is good. Very important thing you told in the last, that because these brachial plexus injuries have not a good prognosis. So these patients should have been counseled beforehand, because they are the young, productive males of the family, bread earner of the family. So whatever they have money in their pocket, they will also lose in the surgery. But ultimately, if they will not gain anything, then there will be problem.
Well,
So now I think we can go for the OSCE.
Yes, sir.
Prashant.
Bansal sir, you can start. You can share your screen in OSCEs.
Okay, in my mobile, how can I share? I have opened the keynote. No.
Yes, sir.
a keynote, right? I think there was some keynote.
Here it's opened, and how to share this. Mm, Can you see the screen?
No, sir.
No.
So we could see for.
I'm putting the keynote on, and it's not shared here.
One minute, I'm just so
Okay.
fine.
Can you, Prashant, are you sitting on desktop, because I was on mobile?
Mazumdar sir, can you share your screen, sir?
Yeah, I'm just trying to share that. Yeah.
It's,
One minute.
OSCE.
Okay, yeah.
yes, sir, OSCE.
So I have four, right? Four this thing.
Yes, sir.
Right. 1 minute. I think I have opened up. Let me share the screen.
Okay.
Yes, sir.
Sir.
1 minute. Can you see it on my screen?
It's coming. It's coming.
Yeah, okay. So this is a 50-year-old. Can you see the screen now?
Yeah.
So 50-year-old male alcoholic smoker fell in ditch 2 hours back. Now has come with bilateral upper limb 2/5, lower limb 5/5, overflow incontinence present. All reflexes are mute. So what is the diagnosis?
It's like central cord syndrome, sir.
So upper limb is 2/5 and lower limb. So there is a bladder bowel, all reflexes gone.
The patient is in
Yeah,
patient is in spinal shock.
patient is in spinal shock. So Patient is in spinal shock because of what?
So could be because of cord contusion.
Cord contusion, yeah.
What contusion? What level? Well, miss, what kind of?
What level are we talking?
So if shoulder involvement is also there, then above C5, below foramen magnum.
Yeah, so somewhere between foramen magnum and C5,
C5.
right?
Dr. Majumdar, your
Yeah.
screens are all coming together. You're not separating one by one, like one slide at one time. So we can see your second slide also, which is the due to the first question answer.
Yeah. So actually, I did not say this was sent to me, so I've opened up the way it was sent.
You can zoom it, sir. You can zoom it. You can zoom it. Zoom it.
Okay, zoom it. Okay.
Yes, sir. Like this.
Yes.
Okay. That is a good idea.
Yes, sir.
Okay. So she said foramen magnum to C. Probably she has seen that slide, right?
Yeah, she has already seen that slide. No issue. She has answered. She has answered like the way she has not seen it.
Okay.
She's so smart.
Yeah, they are very smart, more than okay.
More than us that we were in the exam.
Okay. So, okay, can I go to the second slide now? She said C4, foramen magnum to C4, right? C4, C5?
C5, foramen magnum to C5.
Okay. So what would you do? What is the first investigation would you do in this case?
So in this case, first investigation I'll do is CT scan to see if there is any bony injury or not. First, after immobilization of the cervical spine.
Why not X-ray?
X-ray would be, see, patient has come to ER with all these things in shock, you said, and all that. So
CT will give us more information as compared to an X-ray.
CT will take time, and X-ray can be done immediately, and you can see the dislocation or listhesis or whatever.
So what would you do if the patient comes in here like this? What will be your first thought? What do you need to do?
Immobilize the cervical spine.
Yeah, and treat the spinal shock. You would check the pulse, blood pressure, everything, right?
Yes.
And anything else which would be concerned?
So catheterization, patient might be in urinary retention.
Yeah. And what?
Airway compromise can
It
be.
is not probably mentioned here, but you would certainly be bothered.
Airway compromise.
Airway compromise because of what?
Due to the cord injury and phrenic nerve involvement.
So this is not being mentioned here, but you would always try to stabilize the patient. That's what Dr. Bansal was asking. What would you do in this case when the patient comes to ER? Whether, it depends upon where you are, but I think X-ray is also not a bad option in case the CT is not available, or just to get to know what is the kind of injury. Okay. So, and would you do CT then? If X-ray, what you would like to see on X-ray?
On X-ray, sir, if there is any dislocation that can be seen, if there is any fracture of the vertebral body that can be seen.
What do you mean by dislocation?
As in sir, any listhesis, sir.
What do you mean by listhesis?
As in anterior posterior displacement of two vertebral bodies, as in any loss of alignment.
Okay, so that listhesis is caused by what?
It can be due to any bony and ligamentous injuries.
Or that you probably didn't read in the slide, huh? You missed that. Okay, I thought that you must have read, but you have not read that. So bony injury, ligamentous injury, but when we are worried about such a thing, listhesis, We are worried about something, no, that we may need to do something. What are the parts of the vertebrae which can get affected by this kind of?
Then,
What joins two vertebrae?
the facetal joints.
The facets, no?
Hmm.
What happens to the facets?
So there can be dislocation of the facetal joints, either
Hmm.
perching or locking of the this facetal joints can be noted.
So would like to do CT scan and then what else? If the patient is stable down the line, then
I'd like to evaluate with MRI also.
MRI, what would you see in the MRI?
MRI, if there is any cord signal changes noted.
Or basically MRI for cord regions. Okay. Why do you want to see that? Why you want an MRI? See, we know that obviously patient has come with decreased power in both upper limbs and lower limbs are intact. But why do you still want an MRI? I know certainly for sure that the problem in the MRI. No, reflexes are
For
mute.
prognosticating the patient, sir, if there is a cord contusion present, then we can prognosticate accordingly.
Before showing the MRI, I would like to know from you what would you like to see, and what is the interpretation? How the cord can get affected in these patients?
So either if there is a mechanical compression because of any disc like prolapse disc there which can be which we can which can be dealt with in that case.
So disc is one. Second, so I'm talking about ligamentous rupture,
Posterior long.
yeah, PLL, yes.
Posterior longitudinal.
Then
Disc prolapse and
any bony fragments protruding into the canal. Okay. Facetal, you talked about facets, right? The facetal locking. Now can you see the MRI? Can you see the CT?
अपॉइंटमेंट नहीं लिया हाँ
Prashant, can you mute other one?
So is there any locking or perching? Is there any difference?
if it is completely dislocated, then we call it locking, sir.
Yeah.
If it is just a small displacement, then we call it perching.
Okay. So here, what do you feel it is?
It is perched
Where?
over the 4 and 5 vertebrae, C4 and C5 vertebrae.
Yeah. Okay. So there is no locking, right?
No, sir, it's perching.
Sure.
So here we are not able to see the facet.
So your the more lateral cuts are not there, right? So suppose so here these are the only two films that we have, Prashant.
Yes, sir. For this the next slide we can probably appreciate.
Yeah. Okay. Now you see, we got an MRI for you. What do you see? Well, that's the reason I wanted to ask you about the MRI before showing you the MRI, so that at least I know what you are looking for.
In this, there is listhesis noted at the 4-5 level. Grade 1 anterolisthesis of C4 vertebra over C5. With posteriorly, there is some C4, C5 disc is prolapsed and compressing over the cord, but there is still CSF at the same, that is in different level actually, but the cord appears to be, there is no cord T2 changes do not appear in this sequence. Other than that, the cord, this diameter also appears to be intact all throughout the cord.
Yeah. What I was expecting you from to be told on the MRI was whether there is cord swelling or not. You talked about contusions, edema, cord swelling, and then cord compression. Okay. So here, what do you see? Is the cord swollen?
So, then there is no T2 signal changes noted. So, significant, I'm not able to make out on this
Yeah.
sequence.
If at all there could be a faint T2 signal, you may, this, I can make it more this thing, but could be a faint T2 signal here, you see?
Yes, sir.
Okay.
Then at the C4, C5 level, at the lower end plate, the lower end plate of C4 and upper end plate of C5, there is T2 hyperintensity noted.
Yeah.
Could be marrow edema
Yeah.
because of injury.
Mm-hmm.
Then there is loss of
And you can see
cervical
on the action.
lordosis.
Yes. So there is loss of cervical lordosis. There's not much. There is maybe mild. There's the listhesis and maybe small kyphosis also. So the question here is now this is central cord syndrome. Now with all these things, what do you want to do?
One is patient will require posterior as well as anterior fixation in this. One is because in this it is recommended that patient has unilateral locked facet.
Yeah.
So,
That's it.
so we have to put the patient on traction first, try to reduce that locking. After that, if it is reducible after traction placement, then we can proceed ahead with posterior fusion as well as anterior fusion, since patient has listhesis and disc complexes also there. Or if it is not reducible,
What posterior wait. You said posterior fixation.
yes, sir.
What fixation would you like to do?
The lateral mass screw placement and this fusion with rods.
So if you do lateral mass fixation on the posterior, how many levels you want to fuse?
Sir, C4, C5.
Only two.
Depending upon if there are other bony injuries, then
No, we are talking about disc syndrome,
so here there is not like
Would you like to do pedicular fixation?
pedicle fixations, and usually in cervical we do lateral mass only.
Okay. And anteriorly?
Anteriorly we can because patient has disc complex also, so C 4-5 anti-cervical approach and C4 C5 discectomy and fusion can be done.
Okay. So here, when would you operate? Timing, that the two questions are timing of surgery. So would you want to operate immediately or would you opt to?
I'd like to operate immediately, sir. Since this is an unilateral locked facet, means it's an unstable injury.
Yeah.
And so if we fuse, the earlier we fuse, the sooner we can mobilize the patient.
And what about the
Sooner we can-
prognosis now? The patient has come with bladder problem. Patient has come with upper limb weakness. Lower limbs are okay. So the patient is going to ask you whether I'm going to improve or not. What about my bladder?
Sir, in central cord, because patient may have cord contusion, so in that cases the patient may have persistent distal upper limb weakness even after the surgery.
And
Uh,
bladder?
in most cases it improves, but still some amount of this bladder tension can be persistent in such
So
patients. We'll have to trace.
to give them a realistic expectation that the main and the cord contusion and the cord edema will take its own time to resolve, maybe 6 weeks or to 2 months. And then we really don't know. After some time, the bladder may improve, the bladder tone may improve. It's a young patient, no? So, but the patient is going to ask you whether I am going to have 100% in recovery. Would you give him 100% chance of recovery?
No, sir.
Yeah. So you have to be realistic in this patient that the main aim is to prevent further, because why are we operating if we don't do surgery? The cord contusion may heal after some time, but what is the issue that may occur if you don't operate him early?
So we can promote early mobilization and physiotherapy.
Yes. So that early mobilization, you can be mobile, can be pain-free, and then allow the cord alignment also will improve, and that will help to reduce the edema, and early mobilization will also help his rehab, everything. Okay. Fine. Okay. Now this 33-year-old male left homonymous. Now I am smart. Now I will not show you the next slide, because I also don't know. The 33-year-old male with left homonymous hemianopia, headache since 10 years, diagnosis. What is the diagnosis?
Cellular hyperintensity is seen, sir, left side. In cellular region.
In where?
T2.
If it
In
is
cellular
left,
region, there is.
in what region? Cellular? What is this?
Cellular region.
Left homonymous hemianopia. What does left homonymous hemianopia mean to you?
Optic tract.
Okay. Which side is the lesion?
Left side, sir.
Huh? If it is a left-sided homonymous hemianopia, what fields are gone? What fields are gone? In the right eye, what is the defect in the left?
Right side, there is some subtle hyperintensity seen on T2, sir, in cerebellomedullary. Cerebellopontine angle, some hyperintensity can be visualized. It can be arachnoid cyst.
What is this? But this is interaction or this is extraction?
Intraaxial lesions of brainstem.
What is this? In the brainstem, no?
Yes, sir.
What part of the brainstem is this?
Midbrain.
Midbrain. What is this? So there is some lesions in here. You can see that.
Rectum.
You can see the colliculus.
Midbrain. Yes, sir. Colliculus.
These are the colliculi, no? So you can see the lesion in the left colliculus, right? Isn't it? So what do you think it is? A young male with a lesion in the left colliculus, maybe with a little bit. Anything else you would expect? What do you think is the reason most commonly? Is it causing something to the aqueduct?
Just compressing the aqueduct, sir.
It's a kind of an infiltrative, looks like a little bit infiltrative lesion compressing the aqueduct, right? What I have only one scan there. Anything more you would like to do in this patient? T2 is a T2 axial lesion.
Contrast enhancing picture.
Contrast enhancing. So if I ask you what is the diagnosis here, it's like so intense this thing in the left colliculus. What would be the commonest diagnosis? Tectum, no? What are the commonest lesions?
Brainstem glioma can be there, sir.
Correct. Tectal glioma. So you need if I show you just a T2, then you would like to ask for the complete MR. You would like to have ask for contrast. You would like to ask for
Diffusion sorry, ADC and DWI images.
Okay. So here, can you see something?
Restriction
What is this sequence on the left side?
DWI.
And this one?
ADC.
Okay, so can you see something here?
Restriction
Light
over the
restriction
rectal.
here.
Mild restriction is there.
And what about the ADC?
ADC also hyperintensive with a showing restriction.
So what is it?
It can be a brainstem gamma.
Okay, in epidermal, what would you see?
CSF intensity, it can also show ADC restriction.
Yeah, no. In diffusion method and ADC are different. So
ADC
in epidermoid, no. In DWI, what would you see in an epidermoid?
No restriction, sir, in CSF intensity in DWI.
In epidermoid, you would see no restriction.
Arachnoid, we see no restriction. Epidermoid, there is restriction, and arachnoids, we see no restriction.
Yes, so that is on DWI, diffusion weighted. And we are talking about diffusion weighted on the left and the ADC on the right. So suppose the ADC, if there is a diffusion restriction on ADC on DWI, on the ADC, it is an epidermoid. What would epidermoid show on ADC?
Hypointensity will be, sir, on ADC.
Hypointense, right?
Sir.
Yeah. So here, what do you see on the diffusion?
Hyperintensity, which is showing restriction. Could be glioma.
Okay. Plan, approach. What would you like to do in this case? Suppose so it could be a glioma. You see that there is something else also? You think that is hydrocephalus?
Yes, sir. Due to the aquatic compression, there could be hydrocephalus.
What about this temporal horns?
Compressor.
So then you would expect dilatation or compression?
Compression.
No, in case of hydrocephalus, you would expect it to be dilated or compressed?
Dilated, sir. In case of hydrocephalus, it is dilated, but in this case, we are seeing compression, sir. Temporal horns were not properly visible.
In this case, such a small lesion in the colliculus, what would you like to? What would your plan of action?
Biopsy of the lesion can be done, sir.
Okay. How do you
RMS of craniotomy.
Why do you want to do biopsy?
For tissue diagnosis and for the plan of the treatment.
The patient has got headache since 10 years.
To prevent further deficit and to further undergo, if it is a brainstem glioma, then we can go for radiotherapy, sir, based on the tissue diagnosis.
So how do you want to do the biopsy? What biopsy? How would you approach the lesion?
RMS of craniotomy and biopsy of the lesion could be done.
RMS means retromastoid.
Yes, sir.
The RMS. Okay. What is this?
Perfusion studies.
Yeah. So is it hypertrophic or hyper? Yeah, this tractography, right? Why you would like to see tractography for what?
To see the white matter tracts if they are compressed or they are infiltrating.
Infiltrated. Okay. So here you see something.
It is looking like it is infiltrated in the white matter tracts.
Post-operative, day 5, the patient develops fever. BCS is 9. The patient develops fever means what do you expect?
Meningitis can be expected, sir, in such case.
Yeah. So day 5, patient develops fever. I am just asking. So fever with some neck stiffness or something. So what would you like to give in this case?
So we would like to start with the empirical antibiotics. Send one CSF profile to look for what
Which antibodies
organism
would you like to choose empirically?
so that actually depends.
What is
Depends
that?
upon every hospital have their own policies based upon what is the most common organism.
Uh-huh.
So here at NIMHANS we give vancomycin, ceftriaxone, and this amikacin.
All three at one time.
So usually 2 antibiotics are started and then plus one depending upon the culture.
You would start with the commonest, that is ceftriaxone, because ceftriaxone is supposed to have some CSF for this thing. You would do, and then you would do a CSF.
CSF, we'll send CSF simultaneously start antibiotics.
So you would like to start ceftriaxone and vancomycin together, or only ceftriaxone and wait for vancomycin?
To get usually 2 antibiotics are started together. So
some people would just start ceftriaxone and wait, because ceftriaxone itself can, if the patient's fever goes within 48 hours, then you may or may not add the second antibiotic. You may think, because every antibiotic has. What are the dangers of antibiotics?
Resistance, sir.
Resistance is one thing. Second thing is,
patient can go in AKI.
patient can have systemic issues. Patient can have low platelet counts can go down. So we have to be very, antibiotic itself can cause long-term antibiotic-induced fevers. So they can go into thrombocytopenia. So vancomycin especially, you have to be careful about vancomycin. So that's the reason I was mentioning that you start with ceftriaxone, do the CSF, and depending upon the CSF report, you might, and culture, you might add another antibiotic. So ceftriaxone itself by itself can make the patient afebrile in 48 hours. Because it's a broad spectrum cephalosporin. Okay. ठीक है, Prashant, anything else?
That would be fine, sir. It's 5 o'clock.
Yeah. So Dr. Bansal is having another, is asking, or?
Bansal, sir, you want to add something?
No, this is all right. I have one OSCE too, but the problem is that it's not shared on the mobile phone. I am right now in the.
No problem, sir.
I think it's okay.
Maybe,
I think
and,
it's okay. I think.
and I think we have finished the time also, 5 o'clock. It's
Yes,
already
sir.
5 o'clock. So we can
Yeah.
do it later on, maybe.
Yes, sir.
So should we conclude, Prashant?
Yes,
Yes,
sir.
sir. So
Jay,
yeah, sir. Sir,
Was
first
it
of
okay?
all,
Was it okay? How you have to ask?
absolutely amazing, sir. First of all, I would really grateful and thanks to you, Majumdar sir and Dr. Bansal sir. In the short notice you have joined, and all of us learned so much by the question, answer, and discussion. Thank you, Prashant, for wonderful moderation.
Thank you, sir.
Moreover, there, I think, sir, any comment and as an examiner judgment for Sonal and Prashant, they have done wonderfully, I guess. Would like to advise them.
I think Prasanna and Sonal both have they are very well aware of things, and I think they're quite into the job. But I think fine tuning is necessary. So, for example, Sonal, for you have to be in, you know a lot of things, but they have to be put in the proper perspective. So when we are asking you about CP angle questions and all, you have to know the general things, but to the pertaining to the case, you have to fit that thing into the particular case, because you are going to treat the examiner is asking you questions pertaining to that case. So you have to put your knowledge to use, practically apply knowledge to that case. You understood what I mean?
Yes, sir.
When we ask you what is the difference between extraaxial, intraaxial, what happens after the V patient is put, brainstem distortion, you should be in tune with what you see, all the size of the tumor, right? I had not seen the MRI, but I was sure that the brainstem would have been like completely distorted in this case. On the history only you can make out. So that thing you should make your decision about it. Otherwise, I think You are both are good. Prasanna is also good. She also answered the questions quite well. So I think you need to just fine tune yourself and be more case oriented. Okay.
Very, very nice. Well, thank you. Thank you. Bansal sir, comment?
Yeah, no, though both of them are very good, very excellent. They have presented case history and examination is fundamental, fantastic. Very fundamental things they have taken into the picture. I think they are very good. And the only thing is that Sonal was fumbling for the incidences of the pathology in specific regions like CP angle. She should know that how many percentage of the tumors are there, what kind of tumors are more common in that area, what are the other possibilities like that. And on MRI, the CP angle tumors, usually nowadays we ask them to grade in the Coos grade, like when how much brain distortion is there. These things they have to improve, and the surgery things are very late. If the examiner reaches up to the complication, that means you are through. So
Fair enough. Very well.
And
yeah.
Sonal, you have to be aware that patients are operated in sitting position.
Hmm.
Okay, sir. Jay, sir,
Okay.
we'll wrap up. Thank you,
Thank
everyone.
you.
Thank you so
Thank
much,
you,
Thank you.
Sonal and
thank you, Dr.
Prasanna. Thank you
Bansal,
so much,
and thank you,
Dr. Jay.
Prashant.
Thank
Thank
you.
you, Dr. Majumdar and Prashant and Jayesh and
Thank you,
everyone,
everyone.
and
Thank you.
Prasanna and Sonal and all those people, those who have attended. Thank you very much for
Thank
your
you.
valuable time.
Thank you.
Thank you,
Okay.
Jay, sir.
Thank you.
Thank you.
Thank you.
Thank
Bye-bye.
you, Jayesh. Bye.
Absolutely. Thank you, sir. Bye.
Okay, okay.